Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act. Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane.
We are excited to be back with you once again this week, and we are going to dive into a pretty awesome topic about PCOS. I know many women that struggle with this, so I'm hoping that we can dive into some things that might help you. But before we do that, let us read this week's Bible verse, and mine's coming from Proverbs 2:6. For the Lord giveth wisdom, out of his mouth cometh knowledge and understanding.
And mine, coming from the ether, is Romans 12:16. Live in harmony with one another. Do not be proud, but be willing to associate with people of low position. Do not be conceited.
So, Andrew, so what's funny, I think we have to share.
We do. Yeah.
Andrea came into the outline for this episode, and she was like, I don't remember picking this verse, and I would not have picked this verse. And then as we were going through the episode, I was like, so did you pick out the Bible verses this week? And she's like, no, I thought you did. So to be honest, neither one of us know where these verses came from, but we felt like they were obviously here for a reason. And
Yeah.
I don't believe that they will go void. So
Right.
I hope
Exactly.
whoever needed to hear those this week
Whew.
has
Yeah,
a
maybe
blessing
it's
from
us.
them. Maybe it's us. We were
Uh,
definitely bewildered by them.
yeah.
So, you know
Crazy.
what? We'll just run with it. So, Andrea, today's topic is on PCOS, and I know this is a really challenging thing for many women that they deal with.
Mhm.
I thankfully have never had to experience it. But this is a debilitating uh do you call it a disease? Do you call it well,
Well,
it's called a
It
syndrome,
it
right?
is. Yeah, and there's a distinction between a disease and a syndrome. So a syndrome is almost like a cluster of symptoms. There isn't one specific like mechanism of disease, right? So it's more like a syndrome is often where we see this constellation where maybe some things may exist, but then other things may not exist. So a syndrome can look a little different depending on who's experiencing it. And we'll see as we get into this discussion, we'll see that people's experience with PCOS can vary wildly. And that's part of what makes it so difficult to understand and also to treat. But there may be a time in the future where we have different air quote diseases that spin off from PCOS as we really drill down on what some of the true mechanisms are. But right now they're just we're still kind of in the dark. If somebody tells you they've got some simplified explanation for PCOS, then they really don't understand it. It's a really, really complex thing. So yeah,
So we don't really know if they're hereditary, if they're like
yeah. So some of the features of PCOS may certainly have a genetic component. So like for instance, I always ask my patients, like if you've got menstrual irregularities, I do always ask, so okay, if you had these menstrual irregularities from the time that you were, 13, when you had your first period, what do you know about the women in your family? What do you know about their menopause? What do you know about their history of menstrual issues? Did they have heavy bleeding? Did they have endometriosis? Did they have, all of the things that we think about when we talk about women having difficulties with menstrual issues, because that can certainly have a genetic component. But I don't think that I don't know that the evidence exists. Like, I don't know if the smoking gun exists to say that, well, these particular gene loci are involved with PCOS. If you have, a mutation at this gene locus, then you will manifest PCOS. I don't think that exists. And to further muddy the waters, I feel like often we hang um, genetic predispositions, like we hang our hat on genetic predispositions that don't really exist. Like, something can look like a genetic heritage, but really what it is a lifestyle heritage, right? Because if you have lifestyle and dietary and stress management and, frankly, abuse that exists from generation to generation, and that can look like a genetic predisposition, but really, if you can break some of those cycles, then you can extricate someone from something that looks genetic but really was lifestyle handed down. Does that make sense?
Yeah.
So, like, if your family has eaten absolute garbage from, from your grandparents on down, then some of the things, the diseases of lifestyle that you may be experiencing are just that. They are diseases of inheritable lifestyle issues, but not necessarily genetic.
Okay. So why don't we start from the ground up?
Whew. Yeah.
And just why don't you give us your best stab at what PCOS
Yeah.
is?
Yeah, my best stab. That's a really good way to put it because this is, and again, don't get too hung up on really specific definitions, because what I will continue to encourage people to do throughout the course of this episode is, if you're having these issues, please go back to your providers. Please, keep searching for answers, because it is a really, really complex issue. But PCOS, it stands for Polycystic Ovarian Syndrome. So it would make sense that, oh, PCOS, well, I must have to have cysts on my ovaries, right? It's right there in the name. But that's not really the case. You actually don't have to have cysts on the ovaries. We used to think decades and decades ago that was a feature that had to be there in order for this syndrome to manifest. But now we know that there are other collections of symptoms that are just as prominent and play a major role. So the cystic aspect doesn't necessarily have to exist. So it while the ovaries are certainly, all up in PCOS, like they figure prominently, I will also say that this is also an endocrine/metabolic issue, right? So it would be considered an endocrine disorder. There are metabolic components to it, because we often see weight gain, we see resistance to weight loss, we see glucose metabolism issues with this as well, which kind of features in that endocrine/metabolic dysfunction piece. Then there's also digestive components that are potentially figure in this, and that could be pancreatic involvement. Again, the insulin piece is huge, and that is a digestive component, and as well we've got liver involvement in here, which we'll talk about more later. And then finally we get to the reproductive, and I will say that the reproductive components of this are probably the most prominent that we see in PCOS, but followed closely by the glucose metabolism issues that are rampant. So when we talk about the reproductive system and the hormonal dysregulation that comes along with PCOS, we've got to begin with the ovaries. And so I just want to talk briefly about human female ovaries, right? They and let's just get familiar with what ovaries are. Ovaries are these tiny, tiny little reproductive organs. They're about an inch. They are in a 3D capacity. They will hold approximately 1 teaspoon or 5 milliliters of fluid. So that's how big they are. And they contain, so when a girl is born, a baby girl is born, she actually has all of the eggs that she will ever have for her entire life are in those ovaries. You're born with all the eggs that you're ever going to be able to mature and release. All right. And so that is enough eggs for approximately 400 to 500 ovulations. And so for those of you keeping score out there, that is 400 to 500 menstrual cycles. Yes, that's a lot. Now, the larger the size of the ovary, the greater the reproductive life expectancy. All right. So if someone is born with slightly larger ovaries, we've got women that are like super fertile into their 40s and some even into their 50s. But then also the reverse is true. So if someone is born with slightly smaller ovaries, then their reproductive life expectancy can be shorter.
Mhm.
Okay. Now, again, harkening back to the polycystic feature of PCOS, so that is something that occurs within the ovaries. So the ovaries are full of follicles, and within the follicle is the egg. All right. So each month, what is supposed to happen as a woman is menstruating is each month, the based on hormonal stimulation, a very complex hormonal stimulation, one follicle will enlarge, and then that egg will mature and then release. Now, if the follicle does not then shrink back down after the egg is released, it can become enlarged and stay enlarged. And this is what we mean when we're talking about cysts that we can see on ultrasound. Okay, so that polycystic feature of PCOS is simply enlarged follicles. And some people think that these are just growths on the ovaries, but they're not. They're actually the follicles that have become enlarged, but then they don't shrink back down like they're supposed to. They get enlarged and they stay enlarged. And so then when you look at the ultrasound, you see these kind of lumpy ovaries that can almost have like it's called a string of pearls when you see it on ultrasound, and it just looks like these this string of what looks like pearls, and those are all of the enlarged follicles, and that would be indicative of mini cysts occurring on the ovaries.
So, one question I had when you were talking about it was, so does PCOS tend to go away since we just got done with the menopause episodes? Does it tend to go away after menopause or can it continue?
Yeah, that's a really, really good question. It does. It does tend to go away. However, the issues that a woman will have with PCOS, if it is left just to its own devices and entirely untreated, she can develop things based on the PCOS that are um, that are life altering throughout the course of her life on into that postmenopausal. So it's not just simply the hormonal issues, because as we know, right, a woman's fertility, once that's gone and once the menstrual cycles end, we know where the hormone levels end up, right? They end up in the tank. They're all going to fall. Um, so that part of PCOS does go away in menopause. However, all of the changes that we're going to talk about that can happen to your body because of PCOS, they can have lasting impacts.
Okay. So, when you were talking about the digestive
Mm-hmm.
and the
Mm-hmm.
insulin resistance,
Yeah.
that's probably one of the factors that probably doesn't
Mm-hmm.
go away.
Oh yeah, yeah, and the impact of that. I mean, you can have liver issues. You can have a frank diagnosis of diabetes, um, based on issues with PCOS, right? And then from diabetes, my gosh, we're off to the races. We've got, kidney disease, retinopathies, I mean, just anything you can think of stems
Yeah.
from diabetes, heart disease. So yeah, it's difficult for me to think of any chronic disease state that could not spin off from type 2 diabetes, which can spin off from PCOS.
Okay. So since cysts aren't necessarily a indication that you have PCOS,
Mhm.
right?
Mhm.
You said
Mhm.
that?
Yeah.
Um,
Yeah, no, if you do
we
have the cyst, that is certainly like we look at that and say, "Oh, okay, yeah, we need to evaluate this person for PCOS. Like she may indeed have PCOS if the cysts are present."
mm. So cysts are do most women have them and then they don't cause issues, or if you did have one, then you potentially w- might have PCOS?
Well, okay, so yeah, that's a good distinction. So there are lots of women who will get an ovarian cyst. Okay. And it may even cause problems for them. It could rupture, it could hang out and cause pain, but that is not necessarily diagnostic of PCOS.
Okay.
And the flip side of that is also true. Just because you have PCOS doesn't mean that you have this multitude of cysts within your ovaries.
Okay.
Yeah.
So cysts obviously can rupture, right?
Yes. Cysts can absolutely rupture. And again, this is regardless of whether or not you've been diagnosed, whether or not you meet the diagnostic criteria for PCOS, which we will go into later on. But yes, cysts can rupture, and this is characterized by a like when this happens, right? You absolute right. You absolutely know when this happens. It will manifest like a extremely sharp one-sided pelvic pain in the lower abdomen, and it can be associated with like a hard workout. It can happen after, some form of trauma, like a car wreck. Even after sexual intercourse, a cyst can rupture after that kind of activity. And so it causes severe, severe pain, like shaking, like your sympathetic nervous system is in overdrive. Like you are sweating and shaking, and it's
You are in a third dimension.
God,
So
oh, she knows.
I've only had one that I
Mhm.
think I had. I'm pretty positive I
You
had.
absolutely had.
So it was the first time taking my mountain bike out, my newer mountain bike out, and my dear friend, not Andrea, um, wanted to do this one trail, and Christian was like, "Are you sure?" So he ended up going with us, thank goodness. But yeah, I literally fell down the mountain. Like it was
Mhm,
so bad.
mhm.
Probably I don't know. I probably went down 10, 15 feet. I
Oh
don't
my
know. It
gosh.
was so bad.
Yeah.
And so so we get through done with the trail, and that was on a Saturday. And
I
so
know it was on the
Sunday night,
weekend, I remember. Yeah.
yeah, so Sunday night, I wake up early on Mondays to get down the hill to train, and I woke up at like 2 or 3 a.m. in drenched in sweat, in writhing pain.
Mm,
I was like, I felt like I was hallucinating. I
yeah,
was throwing
sad,
up from so much pain.
right.
It was horrendous. I didn't know what was happening. And so the next day I canceled, my clients that day.
Mhm,
And the next day I was telling Andrea about it. She's like, "Oh my gosh, I think you had a cyst rupture." And I was like,
mhm.
"I don't know."
Yeah.
Like, but
Yeah,
that
and that was a
that
that was a particularly bad one.
yeah.
Yeah, that was real bad. Um, It's not always that bad.
Yeah.
But yeah, you can think you're dying, like, you can see the Lord,
Yeah.
during those. That's yeah.
So I mean, obviously the pain subsided. It when it ruptured and whatever, but
Mhm.
so your body can reabsorb
Uh-huh.
like all of that, like,
Yeah.
and then that doesn't cause like any septic issues or anything.
No, but you know what? Gosh, it's always such a crapshoot when you start telling people, "Oh, don't worry about it. Don't it's fine. Just ride it out." Because sure enough, you guys, you have that kind of pain. You can also have a tubal pregnancy that ruptures, and that is a life-threatening situation. And
Mm,
so I would never tell someone unless I was extremely intimately knowledgeable about their particular health condition. I would never tell someone, "Oh, just write it out." No, you gotta get yourself in, get ultrasound, get imaging, just to make sure, because that can be a life altering event. If it's not a cystic rupture, uh, and even if it is, like, you can bleed. You can
mhm,
bleed from those. So yeah, it does cause severe pain. There is almost the sensation of like pelvic pressure. You can get like an urgency or frequency of urination too. Those can be some other symptoms of a cystic rupture of the ovary. You also will notice like severe pain from a twisting motion. So again, when Ashley was talking about, falling 10 or 15 feet off that bike, you can imagine that, that cyst was probably on kind of a hair trigger. Now, had she not fallen, that could have potentially been reabsorbed into her body, and she
mm,
never would have known it, because this
yep,
happens all the time. But it was just kind of this perfect storm of events, where she had, her body had developed this cyst, and then she had this traumatic event, and it ruptured. And yeah, it was I remember that was a terrible deal.
yeah.
So
Um, so you have a study here, I think?
Um, yeah, and actually I did want to interject also with those cysts. So like I mentioned, it Ashley's, or any other woman, myself, I may have had cysts and just don't know it, and they got reabsorbed. Now one thing that's important to note is that regardless and we haven't talked about treatment options for PCOS yet, but I just want to acknowledge this while we're talking about cysts. So let's say that you get an ultrasound and you've got cysts on your ovaries, and someone wants to put you on oral contraceptives. Now, research has shown that cysts do not reabsorb any faster with the addition of oral contraceptive, this is birth control pills,
Mm,
than they do with watchful waiting. So if someone is trying to tell you that, okay, you need to be on birth control pills because that is the only way that we're going to get these cysts to reabsorb, no, it has been shown that or birth control pills do not make cysts go away any faster than just simply waiting it out. Now, if these cysts are greater than 10 centimeters, that's ginormous, you guys. So 10 centimeters, like 4 inches. So consider if you've got an ovary, I mean, this is like the Death Star, right? This cyst is 4 times bigger than the ovary itself. Then you can consider there are surgical options. You can get a laparoscopic removal where they'll go in via a very small incision, and they will surgically remove that, and then withdraw the lap and sew you right back up. So that is certainly a possibility, is for those giant cysts.
okay. Um,
Diagnostic criteria, that's what's next. Yes. Yeah. So the the next place we'll go here is, how do we diagnose PCOS? So now, in the early 2000s, there was something called the Rotterdam criteria. And it's still, this is primarily what's used today, although many of us in the functional space have a little broader definition set when it comes to diagnosing and treating PCOS. So it's a little bit squishy in my mind, but here's the Rotterdam criteria, and this is what most providers will use. And you need to have two of the following. So the first one is this hyperandrogenization or elevated testosterone. So you can either have a test value that says that you have elevated testosterone, or you can have a clinical presentation, which means basically a clinical presentation just means, yeah, the provider looks at you and says, oh, yeah, I see that you've got X, Y, or Z. So they make what's called a clinical diagnosis rather than a testing diagnosis. So you can have a test looking for elevated testosterone, or you can have a clinical diagnosis of elevated testosterone. And this could include things like hirsutism. This is a particularly troubling feature of PCOS for women, and this is hair growth in places where they do not want it. Hirsutism, and we'll talk a little bit more about this later on, but again, when you ask women, I think it's so important when you're evaluating a woman for PCOS, it's so important to say, what about this is the most troubling to you? Because clinically, you could be in your own mind thinking, oh gosh, we've got to deal with this insulin resistance, and oh, she's got metabolic syndrome, and we really need to get her back to a place of insulin sensitivity. And no, to her, the weird hair growth might be the most troubling symptom of all, and you need to acknowledge that. There's also some cystic acne that can come along with this elevate, and all of these things are based on elevated testosterone. Okay, oily skin, particularly oily skin, like a teenage boy, because right, you've got too much testosterone circulating around. And then finally, there is this male pattern hair loss that can occur. So when we think of male pattern baldness, that's the kind of patterning of hair loss that I'm talking about. So right from the top of the head, right, back even to the crown of the head, and that is quite troubling for women. So not only can you get this weird hair growth like on your chin, below your belly button down to the pubic area, you can get it on the hair growth on the chest, you can get hair growth from the nipples. So if you think about male patterning of hair in places other than your head, that's where you can get it. And as you can imagine, that's very troubling for women. So yeah, those are some of the clinical signs of hyperandrogenization. And then there is a biochemical sign where we would simply do a blood test and see, is there an elevated free or total testosterone? Now, there has been some latitude given in terms of diagnostics now, where you can also consider an elevated DHE. This is a dehydroepiandrosterone, is DHEA, and that is a precursor to testosterone. So the body will convert that to testosterone. So if you get a sensitive DHEA test, that's the DHEA-S test. If you get that and that is elevated, then that is as good as an elevation in testosterone.
Is that
So,
cheaper to get? And that's why they do
well,
that?
gosh, that's a really great question. I don't know the answer to that. I typically will order DHEA as a part of my annual panel. It's part of my hormone panel that I run on everyone annually. And so, I look at estrogen, I look at progesterone, I look at DHEA, and I look at testosterone free and total. So yeah, I don't know. That's a really good question. I've never priced those out individually. But yeah, that may be a consideration for someone. And then finally, so we've got, oh, I'm sorry. So yeah, that was the first thing we talked about was the elevated T. Now also a second criteria is to be anovulatory or oligo-ovulatory. And so this means that you have interrupted cycles. So your cycles are either greater than 35 days apart, or you have less than 8 menstrual cycles per year. Okay. So this would be indicative of someone not ovulating. And usually these periods are horrendous. They come with lots and lots of pain, lots and lots of blood loss, lots of clotting, they're just awful. A lot of times these women have to miss work. It really kind of wrecks their lives for a few days at least. And then finally, if we see polycystic ovaries on like a transvaginal ultrasound, having greater than 20 follicles per ovary in either ovary is considered one of the criteria for PCOS. You can also look and see if she's got an increase in ovarian volume. But I think the follicles are really the primary thing that we're looking for. Like, I will order either a lower pelvic ultrasound or I'll order a transvaginal ultrasound. If a woman is coming to me and she has never had sex before, then I will order the lower pelvic ultrasound. If she has, I will order a transvaginal ultrasound. So there are lots of ways to do this imaging. And that's kind of the criteria. So you can see you can have elevated testosterone or signs of it, and you can have these weird anovulatory or oligo-ovulatory cycles, and that is diagnostic without the polycyst, right?
Mm-hmm.
So
Yeah, and you kind of made a note on the polycystic ovaries. Be careful
mm,
of younger being diagnosed almost too early with
yes,
PCOS.
yes, that's correct. So brand new cycling ovaries. So like think about when you first got your period, you're probably 12 or 13 or 14. Those brand new ovaries, they're still trying to figure stuff out. And so they can look polycystic on ultrasound. So you want to be really careful with your younger women. If you're ordering imaging, or if you're, the mom of a girl who is going through this, we can certainly look into PCOS at this age, but ultrasound imaging is not reliable because you can have ovaries that look polycystic, but really they are just trying to figure stuff out. And so until they mature around the age of 16 or 17, that kind of imaging is very unreliable.
And we'll get to diet, and we're gonna split this up into a couple episodes, but we're gonna
Mm-hmm.
get diet into the next one. But I would be curious of,
Yeah.
making a note of this. Like, so say
Mm-hmm.
you have a teenage girl that's having horrendous periods, like what
Mm-hmm.
maybe getting those better omega-3s.
Oh, sure. Yeah. Yeah, absolutely. And that would certainly help with, glucose regulation. But again, there are lots of different places that PCOS can start from. And, a lot of times it's from a place of hormones rather than a place of metabolism and endocrine. Does that make sense? So if
Mm,
it starts from a place of metabolism and endocrine, then yes, and dietary changes, don't get me wrong, they're going to be important for everyone who meets the diagnostic criteria for PCOS.
mhm.
But I I want to talk a little bit more and maybe kind of round out this particular conversation with what we're looking at now. And I know I'm kind of talking all around what PCOS is, but I want to add a few more things in here that we know now. So I've given those 3 diagnostic criteria that fulfill Rotterdam. However, now we are also adding things like elevated AMH. So this is another blood marker that you can get. This is anti-Müllerian hormone, and this is a measure of ovarian reserve. So we do some very basic fertility work at our clinic where I work, and one of the things that you can do is measure a woman's ovarian reserve. So it's a very Goldilocks thing. If it's too low, then she's not ovulating and she's not, producing mature eggs and follicles. However, if it is too high, this is also not a good thing. An elevated AMH can be a sign and symptom of PCOS. Okay. So that is in the mix also. Now, so you mentioned, dietary interventions. And here is where we can talk a little bit about, like, what does it look like when someone has either downstream or upstream metabolic issues and dysfunction because of PCOS? Well, it can look like difficulty losing weight. It can look like elevated triglycerides and cholesterol in a very young woman where we wouldn't be expecting to see that, right? It can also be blood sugar issues. Like if I get an A1C that's elevated in a otherwise healthy, 26 to 30-year-old, I don't expect to see that. If I get elevated cholesterol patterning, I really don't expect to see that. But PCOS can certainly be part of this picture because it can cause these things. Also, adrenals. If so, stress response is such a heavy part of a lot of these things. So the adrenal glands will also produce hormones, and we'll talk about this a little bit in the next section here. But if the adrenals are the place where PCOS has begun, then we really need to target stress response and stress reduction. And how does a woman deal with the stressors in her life? And I would argue that's good for everyone, but particularly for the PCOS that starts in the adrenal glands. And then you also can experience indigestion, heartburn, early satiety. So you'll hear women say things like, I get super full. I eat like half a serving of this or that, and I'm just like so full. I can't eat anymore. Well, that's weird. that's an early satiety. And that really needs to be figured out. Now, again, I want to make a distinction here. Don't diagnose yourself, because some of these symptoms, like the early satiety or a feeling of pelvic congestion. And we talked about this with the menopause issues, but I want you to know that those can also be signs of things like ovarian or uterine cancers. And so you've got to get in and get these things checked out. But also know that indigestion, heartburn, early satiety, these can also be symptoms of PCOS. Now, an ovarian rupture, as Ashley so unfortunately experienced, can also lead to some tachycardia and hypotension. So that is a racing heart and a low blood pressure. So feeling kind of dizzy, feeling kind of nauseous, maybe to the point of throwing up because the pain is so bad. So those are all symptoms of potentially PCOS.
Okay. I mean, yeah, it's a lot.
It is so much, and that's why I'm saying, like, there is so much involved in this, and I'm just hitting the high points today. And in fact, I'd be lying if I said I had it all figured out. Nobody has this all figured out. So yeah, I'm
And I think
still
that's what's
learning.
frustrating about all of this,
Mhm.
even with the menopause episodes. It's not
Right,
just a black and white answer
right.
or question even. Like,
Yeah.
I'm experiencing XYZ. What's my problem? And it's like, well,
Mhm.
it's not as simple as that. And so that is
Right.
why working with somebody, like, your primary care that
Mhm.
really is interested in diving deep with you and, um, that is okay with you asking questions
Right.
because
Right.
you want to understand and not just because you wanna be annoying, you know?
Mhm.
Um,
Yeah.
and making sure that you're not just putting a Band-Aid on things because, like
Right.
Andrea says, there are, consequences or things that you're gonna have to live with post-menopause
Mhm. Yeah.
that if you
Yeah.
did have untreated PCOS,
Mhm.
that you're gonna live with for long term, not just for the short term.
Right. Right. So it's not good enough to just say, "Oh, well, I'm 40 and I've got these PCOS symptoms and a pretty clearly diagnosable PCOS. I'm just going to wait it out because I know my hormones are going to drop anyway in menopause." That's
Right.
not good enough because there's going to be some far-reaching effects from this.
Yeah. So, what are the primary hormones involved with PCOS?
All of them. All, all of them. Uh, there's yeah, it's absolutely crazy, the hormonal dance, and I know I've mentioned this before, but women are so complex. We're just these giant, like, b balls of complexity. Like, we're fearfully and wonderfully made, but man, is there a lot going on. Um so I think where in order to answer that, I think what I'll do is just focus primarily on the sex hormones, which are the estrogen, progesterone, and testosterone. And then where necessary for explanation, I'll throw in the follicle stimulating hormone and the luteinizing hormone, and maybe some DHEA in the middle of that. But we'll focus on those three primary hormones. So the first one is estrogen. And estrogen is kind of the queen of the female hormones. It and I want to make a distinction here right up front. So there's more than this. Keep in mind, there's more than this, but there are two primary forms of estrogen. One is called E2 or estradiol, and then the other one is called E3 or estrone. It's sometimes called estriol.
Mm,
Okay, so diol to triol 3. And just so you know, if you ever read estrone, that's the same as estriol. So estradiol, this is kind of the good guy estrogen. And it comes from a couple of places. It comes from ovaries and aromatization. So there's a process by which the body will it will take testosterone and it will convert testosterone into estradiol. All right. That process is called aromatization. Now, in people who abuse performance enhancing drugs like testosterone, steroids, right? So we all think of like the pumping iron, these giant people. You think of the side effects that occur with using testosterone analogs in male bodybuilders, right? And so there's a condition called gynecomastia where they will grow breasts
mm,
from the use of too much testosterone. Now we think, why the heck would that happen? It's precisely because of this aromatization that occurs both in male bodies and female bodies. So in a male, their bodies know if they have supra or elevated supra physiological levels of testosterone, and their bodies will say, we got too much of this stuff floating around. We got to do something with this. So it'll shunt it to the peripheral tissues in a man, and it will then convert it to estrogen. So which is kind of a dirty trick because they're trying to get big, and then their bodies end up making like extra female hormones. So that's not what they want. And they can even grow breast tissue in response to that. So the same thing is true in women. If if we get a little too much testosterone, or if the body creates too much testosterone, then we've got this mechanism by which the peripheral tissues can convert that testosterone into estrogen. Okay, so that's where estradiol comes from. The ovaries create it, or it can be aromatized from testosterone. Now, this is decreased in PCOS. All right. So the ovarian production of estradiol or that good estrogen E2 is decreased, and so is the aromatization. So we're not getting those big levels of estradiol in a lot of forms of PCOS. However, then the brain says, oh, we don't have enough estradiol. So what I'm going to do is I'm going to start to stimulate more production from the ovaries. I'm going to knock on the ovarian door with follicle stimulating hormone, luteinizing hormone. I'm going to try and enhance the ovarian production of estrogen. Now, meanwhile, remember, we said that this is also a disease or a syndrome of glucose metabolism, right? So in a lot of women with PCOS, not all, there is another very specific type that does not have this issue. And sometimes these are lean, very, very athletic women who are extremely lean can also have PCOS, okay? But the stereotypical, if that exists, the stereotypical PCOS woman has difficulty losing weight and probably has some excess adiposity or fat tissue around the middle. And so this particular tissue creates E3 or estrone, okay? So keep in mind, the brain is taking the temperature and saying, hey, we don't have enough estradiol. And so it's trying to get the body to create more estradiol. Meanwhile, the fat tissue is over here creating all of this E3. And so you get this mass excess of estrogen. Now, estrogen and progesterone, I know I mentioned this in the menopause issues, but I'll say it again. Estrogen and progesterone, they have to be in balance with one another. All right. So we get it's sort of called unopposed estrogen. All right. So if you think about progesterone and estrogen working in conjunction with each other, they almost oppose the activity of each other. So one keeps the other from acting unilaterally. All right. Now, if you have unopposed estrogen, then that leads to havoc. And what estrogen does to the lining of the uterus is it thickens it. And so if you've got all this estrogen floating around and very little progesterone, which we'll talk about here in a second, then the lining of the uterus gets thicker and thicker and thicker. And think about this, you're not developing a follicle, right? At this time, you're not releasing an egg because you're not able to cycle normally. And so your lining of your uterus just gets thicker and thicker. So by the time you finally do have a cycle, it's awful. It's awful. There is so much tissue that has to get expelled that you're having these horrendous periods. But you're only having less than 8 a year.
Mhm.
Okay. Does that make sense?
Yeah. So, like, if that's what you're experiencing, I mean, I think you're gonna get into ways to help with this, but
Oh, yeah, yeah.
so
Yeah.
what?
Probably in the next one.
Okay.
Yeah.
So we'll talk about ways that, so if you are experiencing what she just described,
Mm-hmm. Mm-hmm.
ways
Yeah.
to help with that.
Oh, for sure we will. Yeah.
Okay.
So this leads to a condition called dysmenorrhea. That just means dysfunctional menstruation, or menorrhagia, which is excessive bleeding during your period. Now, this excess bleeding in fact, in menstruating women, the single highest cause of anemia is menstruation, right? Because there is a monthly or however often a blood loss event, and the body finds it really hard to recover from that, especially when there are these thickened uterine lining, and then the blood loss is really pretty profound. Okay. So And then, oh my gosh, and then iron loss leads to more estrogen, and it's just like this vicious cycle. So now let's talk about the progesterone that is needed to balance that estrogen. All right. So one of the roles of progesterone is to actually stop the thickening of the lining of the uterus. So if you look at a female hormone cycle map and you see like when these hormones their levels start to increase and when they decrease, you'll see that around day 18 or 17 of the cycle. Now, this, as you can imagine, this is right after ovulation, right? Because ovulation occurs pretty much mid-cycle. So around day 14, we get ovulation, which is where if everything is happening normally, we get an egg that's matured and then it is released from the follicle. That's ovulation. So that mature egg is released. Then day 14, 15, 16, we've got the thickening of the lining of the uterus because it's ready for implantation. So if the egg gets fertilized, it needs a nice thick uterine lining in order to be able to support the pregnancy. But on day 17 or 18, around there, you'll see progesterone start to rise. Now, one of the and estrogen drops, okay? So one of the features of progesterone is that it puts a stop to the thickening of the lining of that uterus, because otherwise it would just keep getting thicker and thicker and thicker. And then we, can end up predisposed to even endometriosis. All right. So you stop the thickening of the lining of the uterus, and then but in PCOS, when the ovaries don't ovulate, they don't release an egg, right? And this is all based on some very complex luteinizing hormone signaling. But if the body doesn't ovulate, then progesterone is not released. So remember, day 17, you're supposed to have this increase as progesterone starts to come up. But if you don't ovulate, it never comes up. And so you keep getting these excess levels of estrogen. The lining of the uterus gets thicker and thicker. And then again, all of the problems we just talked about. Okay. So, horrendous period results. Now, the next thing I'll talk about is testosterone, because remember, this is a key feature of PCOS, is this elevated levels of testosterone. And so let's just talk for a second about where does testosterone come from. Well, 25% of all the testosterone created in a female body comes from the ovaries. All right. Then 25% actually comes from the adrenal glands. And these are these pyramid-shaped glands that sit on top of your kidneys. And they make testosterone. And then the last 50% of testosterone is created in other tissues around the body. So the adrenals also, not only do they make testosterone, but they make precursor hormones like DHEA. Now, DHEA goes around. Remember, I said you can either measure testosterone or you can measure DHEA, because DHEA is almost like a proxy for testosterone. So if it's elevated, then you also have elevated T. Okay.
Is it common if you do have PCOS that you also potentially have adrenal fatigue?
Yes, I would say that it is common.
Yeah.
Yes, I would say that there is, because again, look at all the issues with glucose metabolism and PCOS, and then look at all the issues with glucose metabolism and hypercortisol, which is all part of that stress response, right? And stuff starts overlapping and getting real muddy, right? So yeah, absolutely.
Okay.
Now, so we've got now we know where the testosterone comes from. Okay. Now remember, when you've got testosterone, your body is supposed to aromatize it and create estrogen. But in the PCOS body, that's not happening. All right. So once you have too much testosterone, This then impacts the ovaries and tells them not to ovulate. And so you can see it's like this vicious cycle. Now, you can also probably tell, as you just mentioned, Ashley, we need to determine, does this come from a problem with the adrenals, or does this come from a problem with the ovaries? Okay. So one way to tell if it's an adrenal issue, you can measure DHEA-S, the sensitive DHEA test. You can measure DHEA, and if it's elevated, it is likely an adrenal origin of PCOS. So we would need to go after metabolic and stress response and all of those things, heavy and hard before we hit hormones. And this is also going to be the patient who likely struggles with weight loss, who likely struggles with, that central adiposity. And the ovarian damage in that case is just kind of collateral damage. It doesn't, the disease genesis, it doesn't originate in the ovaries. They are collateral damage.
Can you get PCOS later, or can you be diagnosed, I guess, or experience more issues of PCOS later in life, or is it pretty typically caught in like your teens and 20s?
Well, okay, yes, and
That's
yes,
one of Christian's favorite responses. Yes,
right.
and
Yes, a terribly unsatisfying answer. So yeah, so my experience in clinical practice has been that there's a lot of women that have dealt with PCOS issues and were stuck on birth control pills for decades, sometimes. Absolutely decades. And so I would say that just because I give them the diagnosis of PCOS in their 40s, it doesn't mean that they weren't struggling with it in their 20s, because they were.
That was just masked.
Yes, exactly. It's just masked with outside exogenous synthetic forms of hormones, which cause other problems. And so, and actually we're going to get into some of that in the next episode. So stay tuned for part 2, PCOS. And we'll talk about, some of the things that your provider needs to check if you're having PCOS-ish symptoms. And then we'll also talk about what can we do about this.
Yeah, absolutely.
Okay.
I'm excited because, I mean, come on. Y'all are probably just like, "Could you just tell me what to do?"
Well, we need to understand where this comes from, because honestly, and I'll just tell you right now, the solutions to this are as wide sweeping as the problem is. And so it's a big ask when you want to heal someone, because with regard to root causes, it's a big ask. And often they have to change a lot about what they do, what they eat, how they manage stress, etc., how they move. And so it's a big ask, and I like people to understand why I'm asking big things from them.
I love it. Yeah, so understanding all of this hopefully will help you in the next episode realize, okay, this is why it all makes sense.
Yeah.
Yep.
It's our hope.
Well, with that, we are going to wrap this first episode of PCOS up, but definitely stay tuned for our next episode where we, like Andrea said, get into some of the things that you can actually actively do if you are struggling with PCOS. So with that, thank you so much for listening, and we will catch you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.